subcondylar bone marrow. So it's a subcondylar bone marrow edema. But this one is going through the ligament, through the soft tissue, and here the patella. That's a fat sat failure. And it's probably because of the coil displacement here. So sometimes you just make sure that that would not happen. This is a very bad image. What are you gonna expect me to tell you about this? Clinically, I may say that the meniscus is normal. The problem with our scoring system, you will see it, it's so detailed that some of the question will not be answered with this quality. You know, the zebra artifact, because of the motion, is not good at all. Look at the cartilage here. I don't know what I'm gonna say with this cartilage. It's not good image. Yes?
Poor quality MRI as opposed to poor quality patient's ability to hold.
Oh.
Now, what happens when we've done it twice? Because this is the 10 to 12 minute scan right here where we're going to run into that.
Yes.
How many times?
Very, very good question. You are going to run to these patients. That's why I said, when you see this patient, please make sure that to explain to him everything, to put them in a comfortable position, to avoid to have a bladder which is whatever, to avoid to that the patient, when you put the patient, ask him if the hands are okay, your legs are okay, etc. Everything, because if they don't tell you that, as soon as you put actually the patient into machine, they're gonna start actually moving, and then you are in a big mess with him and the exam, etc. I do think part of the deal is Meg as well. Megan has to do a great work there. Meaning, if the patient has involuntary movement, motion, whatever, those patients, they should be actually excluded. Patient that has pain, a lot of pain in the knee, they should not be included as well. I mean, pain where they cannot sit in the MRI, they cannot still, be still in the MRI. We should not take those patients. Why? Because they're gonna move and the MRI will be of such quality. Now, you're gonna find some of these guys that they don't know, but when they get into the MRI, and especially if it is long enough, they're gonna be moving. And that's why I said, you help them with taping the knee, you help them with putting the pad, you help them with everything, comfort, etc. If you don't, if you end up with this quality, I do think we should stop. I mean, you do it once, then you go to the patient, sir, you're moving. Do you feel that you are moving? I said, no, I didn't. Okay, so are you in pain? Do you want something? I don't know. You just ask him, try to find out what's happening. If the patient repeatedly is doing this, just get him out.
So one repeat.
It's unnecessary. Huh?
One repeat.
It's one repeat, yeah. You cannot go for two. I mean, again, it's not a repeat without asking the patient what's happening. Because if you repeat it again, you're gonna have the same thing. If you don't go to the patient and ask him what's happening, because maybe the guy will say, oh, I'm peeing on myself. What are you gonna just do, the poor guy? It happened to us all the time. Boston Medical Center, it's an indigent hospital. We have people you don't even imagine. Sometimes they are afraid to say what they are happening to them. They don't, because they are shy and they are actually ashamed, maybe, from what's happening. So you get actually this kind of image. The first thing that we had when we bought actually the last MRI, which is last July, it's new, brand new. It's the propeller. It's the propeller. A propeller. What is the propeller? It's actually when you get actually this kind of MRI with motion, you try to get the propeller so it gets you the motion. It registers the motion and try to correct it. So you get this image, after propeller you get a perfect image. You get it?
How long is that sequence?
Exactly. No, that's the caveat. I mean, always. You cannot buy something. You know what? You cannot run a Ferrari the same way that you run a Honda Civic. It's not possible. You're not paying the same money. Now, if the Honda Civic is running well until San Diego or Las Vegas or whatever, it's okay. Everybody is happy. But be careful, the Ferrari will be actually arriving before you, whatever happened. Unless the guy is actually an idiot. That's what's going to happen, because he paid the price for that. And this is exactly what I'm saying. But if you want to salvage the patient and you have the propeller and you think that he's done well for the 4-5 sequences and then at the end he's becoming like this, maybe because it's a long sequence and a long examination. Now you can use the propeller for the last 2 sequences, for example, and we thank you for that. But if the first sequence is like this, forget about it. And you cannot correct it, of course. Forget about the patient. It's not a patient, because this patient is going to be given as a hard time for the whole examination, and it's useless.
As you progress, obviously, we want to start off the study. We're doing both knees. Would we want to do the affected knee first? I mean, since we're dealing with the progression of potentially that.
You don't know. You don't know. You don't know. I don't know. No, you don't know. You have no idea. And by fact, if we don't also demonstrate that there is a difference, it's useless. So if you don't do the 2 knees, it's useless. We don't know. I don't know. You don't know. And the FDA will tell you, okay, show me the data. You're going to tell them, no, I cannot, because the patient could not actually do the second knee. No, you don't choose. You start right, left knee, always, with every single patient, right, left knee, always. You start with the right, you do the left. That's it. That's about it. This is, again, the poor quality that we don't want. I mean, it's obviously, the patient is, moving all over places. Not good. Not good at all. And then here, the aliasing. So, small field of view. What you have here, you have part of it, which is, this is the posterior aspect. No, it's anterior. This is the posterior aspect of the soft tissue, which is now anterior. Now, is this a big problem? No. At this point, no. Why? Because the patient probably necessarily wanted actually 16, and we put it in a 14 field of view. Now, why I'm saying it's not a big problem? Because it's not going to prevent me to give a very good assessment on semi-quantitative and quantitative. But this is where it's annoying, because now the aliasing here, it's really going on the anterior patella, and I need that cartilage and I need that information. Okay? And again, this patient, again, you see it, a huge, and it's all the way on the patella. I don't need it. And you see here, look at how beautiful it is, the bone marrow, saturation, it's all hypointense. While here, the bone marrow of the patella is hyperintense. It's not because it's pathologic. It's not because there is a hyperintensity. It's just because of the aliasing here, of the wrap from the posterior soft tissue on the anterior patella. So what you do to resolve this is just make it a bigger field of view. That's it. Sorry? Of course you can, but I do think for this patient is a big patient. Of course. We will ask you look at protocol every time to push the bottom of no phase wrap. We'll ask, look at it, it's there. Please push the bottom of no phase wrap. But you will obtain this even if you do it because the patient is big. Look at how big it is. The big patient. You see only part, you don't even see the popliteal artery there. So you need actually to increase a little bit actually your field of view. Again, see this patient, 12, we started with 12. Okay, even you do the phase wrap, you got a lot of wrap in here. With 16, with the 14, it's better. And now you see here you don't see the popliteal cyst. You see the popliteal cyst here. So he has a lot of soft tissue. And I do think with this patient, we do better if we get him a 16 with a no phase wrap, but a 16 field of view because he's just have a humongous knee. That's what happened. This is what I told you about, guys. This patient didn't know. He never had surgery. He never have anything. He just, doing a lot of sports, and he fell once, and he had actually a small, tiny, a glass penetrated posteriorly to the knee and got actually to us, and he said, I've never had anything. We did actually the x-ray, and it shows a little bit small, tiny, opaque, I would say particle, and that's actually metallic artifact. That's what actually will give you when you have a small, tiny, piece of glass within the soft tissue. Poor quality of MRI. Unfortunately, again, clinically, we can say whatever we want, but for this research, for this clinical trial, we cannot. We will not be able to do the job. So we need really to exclude these patients, unfortunately. And it's better for autotraffics to know that this patient cannot be included because of the MRI and the artifact, better than getting this patient going, injected, etc. And then at the end we said we cannot actually read them. Yes.
So if we see this, we stop.
You can stop, send me the images, okay, make sure that it's really in the soft tissue, or you may continue actually the exam, send it to me, and I will just get it out of the study, by the way. Okay, it's maybe better even actually to continue your study, because it's up to me to decide, meaning that I will take responsibility to say this is really metallic artifact in the patient. We will not have any actually better images. Then maybe if you stop here, then they will tell me, do you think that the tech stopped it and he has, he's right or not right, etc. So I do think it's better that I take responsibility than you take responsibility. You are asked to do the exam, do it as is, and then I will take responsibility. But one thing, if you see it coming from outside, if you see it's outside the soft tissue, make sure you don't have something within the machine. As I said, the last time we have it is a coin of quarter just falling from the, I think the guy put it in his underwear, and that went actually from the underwear to things. That's what he said. I don't know why, but that's what happened. So you just don't want that actually. So you go actually collect the 25 cents a quarter and just get it actually the patient done the right way. This one is obviously intra articular, so not necessarily it would not actually help the patient, whatever. This is the most important slide in all my presentation. And clearly, why it's important. Follow